My name is Jeffrey Shirley. I'm a D&P student at the University of North Georgia. This presentation is on the D&P project I completed entitled Improving the Utilization of Continuous Glucose Monitors, or CGMs, in Clinical Practice. The purpose of this project is to improve the utilizations of CGMs in clinical practice, to provide an educational intervention for employees at an endocrinology clinic in Central Georgia to increase their knowledge and acceptance of CGMs, to introduce a new practice protocol on how CGMs are used in the clinic, to increase the rate of CGM interpretations performed at the clinic, and to increase the prevalence of patients using CGMs at the clinic. The PICO question for my project is, will providing an educational intervention on CGM technology and developing a new practice CGM protocol at an endocrinology clinic increase the employees' knowledge and acceptability of CGMs, increase the rate of CGM interpretations performed, and increase the prevalence of patients using CGMs over a 3-month period. Diabetes is a devastating disease, and its prevalence has been exploding in exponential proportions. In 2000, 11 million people in the United States had diabetes, and that number rose to 38.4 million people in 2021. By 2030, it's estimated that 55 million people in the U.S. will have diabetes. Diabetes leads to serious complications. It was the 8th leading cause of death in 2021. It is the leading cause of cardiovascular and renal disease, and patients with diabetes tend to have lower health-related quality of life scores. According to the CDC, glucose monitoring is, quote, the most important thing, unquote, an individual can do to manage diabetes. Traditionally, self-monitoring of blood glucose was performed using a glucometer and test strips. This involves a painful finger stick. It also only records the reading at the moment that the patient chooses to check their blood glucose levels, and it provides minimal data on trends. Diabetes technology has advanced rapidly over the past several years, and now people can use CGMs to monitor their blood sugar. CGM constantly measure and record blood sugar levels. They can provide the patient with alerts for critical hyper or hypoglycemic events. CGMs provide real-time glucose levels. Instead of having to pull out a glucometer and poke their finger, all they have to do is look at the CGM receiver or a compatible smartphone, and they can see their current glucose values. They also provide the patient with retrospective data on their glucose trends. Patients can look back and see their blood glucose levels 24 hours a day. This allows them to see how their behavior and actions impact their sugar and can help them to be more mindful of the things they need to do to control their diabetes. These data can also be used by providers to identify education gaps and collaborate with the patient on therapy adjustments to their plans of care. A provider may perform a formal interpretation of CGM data either during a patient visit or between appointments if needed. A minimum of 72 hours worth of data must be recorded and reviewed with the patient and be properly documented. 95251 is a billable CPT code that reimburses the provider for this service. For Medicare, this service can be billed every 30 days. One important item to review on the CGM report is the Glucose Management Indicator, or GMI. This was previously called the Estimated A1C. It provides the average glucose value based on the sensor data and may be a more accurate estimate of a patient's current level of glycemic control than the A1C. CGM consists of 3 main components: a sensor, a transmitter, and a receiver or smartphone. The sensor is a thin wire that is inserted through the skin into the subcutaneous tissue. Glucose diffuses from the blood into the interstitial fluid, and the sensor measures the glucose level in the interstitial fluid. The transmitter sends this information to a reader, and this is converted to an estimated blood sugar level. There can be up to a 15-minute lag in CGM readings. Here are some facts about CGMs. They were first introduced in 1999, and as previously discussed, provide real-time and retrospective data. They also assist in the development of plans of care. Individuals using CGMs have been shown to have a significant improvement in glycemic control and quality of life when compared with those using only glucometers. Some things to consider about CGMs. CGMs do not directly measure glucose in the blood. Again, they measure the glucose level in the interstitial fluid, and this is converted into an estimated blood sugar value. It is not likely that a sensor reading will exactly match a glucometer reading if checked simultaneously. There are some things that can provide false readings to the sensor. Depending on the brand, acetaminophen or vitamin C may lead to false highs or lows. Another thing is compression. Extended compression on a sensor can cause false readings, particularly false low blood sugar readings. So if someone is sleeping on their arm and compressing the sensor, it's very possible they could get a low alert even though they're not actually low. It's important to verify alerts with a finger stick, especially in a situation in which an asymptomatic patient may receive a critical low alert. Any kind of treatment therapy should be based on a finger stick if the sensor and finger stick do not match within 20%. As CGM use becomes more widespread, insurance companies have expanded their coverage so that more patients may receive the benefits that CGMs have to offer. In the past, CGMs were typically only covered for people with type 1 diabetes or those on insulin pumps. CGM use is now becoming more common in individuals with type 2 diabetes, so coverage for CGMs have changed over recent years. For example, Medicare will now cover CGM use if one or more of the following three criteria are met: any patient on insulin, anyone who has had two or more readings below 54 despite multiple modifications to plans of care, or anyone with diabetes that has had at least one critical hypoglycemic event. This is defined as having a reading below 54, experiencing an altered mental or physical state, and requiring assistance by a third party, like a family member or EMS. In the past, Georgia Medicaid did not cover CGM use, but as of July 2024, they began following the Medicare coverage criteria. Commercial insurance coverage may vary, but at a minimum tends to follow Medicare guidelines. Some insurance companies may now even cover CGMs for any patients with diabetes, regardless of their therapy. The American Diabetes Association updated their clinical guidelines in 2024. The guidelines now state that CGMs should be offered to all people with diabetes, especially those with type 1 diabetes, people with type 2 who are on multiple daily injections of insulin, use basal insulin, and are capable of using a CGM, or anyone unable to achieve glycemic control, especially in the setting of hypoglycemia. The guidelines now state that early initiation of CGMs is beneficial to all patients with diabetes. These are the objectives of the project. The first is to increase the clinic employees' knowledge and acceptance of CGMs. Second is to increase the rate of CGM performed at the clinic during the 3 months after the intervention when compared to the rate 3 months before the intervention. And lastly is to increase the prevalence of CGM use in the clinic 3 months after the intervention when compared with the prevalence of use at the time of the intervention. This is a quality improvement project utilizing a quantitative design. It entails pre-test and post-test, an educational intervention, and a new practice protocol, all to determine if these interventions can lead to an increase in knowledge and acceptance scores, an increase in CGM interpretations after 3 months, and an increase in the number of CGM users after 3 months. The theoretical framework for this project is the IHI's Model for Improvement. There are 3 questions associated with this model. First, what are we trying to accomplish? For this project, we tried to increase the knowledge and acceptance of CGMs by the clinic employees, to increase the rate of CGM interpretations performed at the clinic, and to increase the prevalence of CGM use at the clinic. The second question is, how will we know that a change is an improvement? This project answered that questions with pre-test and post-test surveys on the knowledge and acceptance of CGMs by the clinic employees before and after the educational intervention. The rate of CGM interpretations that occurred for 3 months prior to the intervention was compared to the rate of interpretations during the 3 months after the intervention. The prevalence of CGM use at the time of the intervention was compared with the prevalence of CGM use 3 months after the intervention. The third question is, what change can we make that will result in an improvement? This project provided an educational presentation on CGMs to the clinic employees and implemented a new practice protocol for how CGMs are utilized at the clinic. This all followed the Plan, Do, Study, Act framework. In addition to the model for improvement, the project also was guided by the Technology Acceptance Model, or TAM, developed by Davis. This model proposes that the use of any technology is determined by the user's perceived usefulness or knowledge and perceived ease of use or acceptance of that system. We see in the model that external variables impact the perceived usefulness and ease of use of technology, which influences the attitude toward using the technology, which in turn leads to the behavioral intention to use and ultimately actual system use. This model has been found to be valid and reliable and has been used extensively in healthcare. Keeger et al. In 2018 used this model to evaluate the use of continuous glucose monitors. As part of the technology acceptance model, Davis created the TAM survey. It consists of 6 questions on the perceived usefulness and perceived ease of use of a technology, and is scored on a Likert scale ranging from 1, strongly disagree, to 5, strongly agree. According to Davis, the higher the TAM score, the more likelihood of system use. This is an overview of the project. A pretest was given to the participants, followed by an educational intervention. After the intervention, a post-test was administered, and the new CGM protocol was then implemented. Data was then collected 3 months after the educational intervention. The project took place at an outpatient endocrinology clinic located in central Georgia. The clinic specializes in advanced diabetes management and has experience with CGMs. In addition, the clinic has an existing CGM program, and the project was intended to try to improve this program. There are a total of 25 employees at the clinic. All 25 employees of the clinic were asked to participate. A G-power calculation determined that a sample size of 15 participants was needed for this study. Inclusion criteria included being a current employee at the clinic, being 18 years of age or older, and having the ability to read and write in English. Anyone who did not attend the entire educational intervention or did not fully complete the surveys were excluded from participating. Participants were recruited through convenient sampling, and informed consent was obtained at the time of the educational intervention. After obtaining consent, a demographic survey was collected from the participants. Knowledge and acceptance were assessed using pre- and post-test. The knowledge assessment consisted of 6 questions on the use and benefits of CGMs that was developed by the primary investigator and the content expert. Acceptance was assessed using a 6-question modified TAM survey on the perceived usefulness and ease of use of CGMs. The knowledge assessment demonstrates content validity as it was developed with the content expert and experienced endocrinology. The validity of the TAM has been established with multiple studies. The internal consistency and reliability of the TAM were first determined by Davis in 1989, and this has been confirmed through multiple studies in the past several years. The project intervention consisted of 3 main components. First, a 1-hour educational program on CGMs was given to the participants by the primary investigator, an advanced practice nurse board certified in advanced diabetes management. Second, a new practice protocol for the workflow for patients using CGMs. This involved identifying patients who use CGMs and flagging their charts, the development of a new process for obtaining CGM data, and recommendations to the providers on completing CGM interpretations. Third, the development and distribution of a 1-page educational handout created by the PI that simplified the instructions for patients to link their devices to the clinic database. To determine the rate of CGM interpretations, the total number of patient visits that included the CPT code for a CGM interpretation, or 95251, was provided to the PI by the clinic, as well as the total number of visits that included a diabetes-related ICD-10 code. The total amount that occurred during the 3 months before was compared with the total during the 3 months after the intervention. The rate of CGM interpretation was calculated by dividing the number of encounters with the 95251 code by the total number of diabetes visits. To assess the prevalence of CGM use at the clinic, the total number of patients in the clinic CGM database was divided by the total number of patients in the clinic being seen for diabetes. A patient is considered active at a clinic if they have had an in-person visit within 3 years. So the number of clinic patients with diabetes was determined by calculating the total unique diabetes encounters that had taken place within 3 years. The prevalence of CGM use was determined just prior to the educational intervention and was then compared with the prevalence 3 months after the intervention. Data analysis was completed using SPSS 29. Demographic data was analyzed using descriptive statistics. Knowledge and acceptance scores were evaluated using descriptive statistics and a paired t-test. The rate of CGM interpretations and the prevalence of CGM use were analyzed using descriptive statistics and by calculating a two-population proportion z-score. IRB approval was obtained from the University of North Georgia prior to beginning the project. 20 individuals attended the educational intervention, but 2 of them did not properly complete the survey and were thus excluded from participating. 10 of the 18 participants were clinical staff. All participants had completed high school, with the majority having completed undergraduate or higher education. The maximum knowledge score that could be obtained was 6. The mean knowledge pretest score was 2.89, and the post-test score was 4.83. There was a statistically significant increase in knowledge scores after the intervention, with a p of less than 0.01. The maximum acceptance score was 30. The mean acceptance score was 24.11 on the pretest and 26.39 on the post-test. With a p of less than 0.01, there was also a statistically significant increase in acceptance scores after the educational intervention. During the 3 months prior to the intervention, the rate of CGM interpretations was 330 per 1,000 diabetes visits. This increased to 345 interpretations per 1,000 diabetes visits during the 3 months after the intervention. Despite the increase seen, it was not statistically significant, with a p-score of 0.98. At the time of the intervention, there were 201 CGM users per 1,000 total clinic patients with diabetes. There was a statistically significant increase to 224 CGM users per 1,000 clinic patients with diabetes after the intervention, p less than 0.01. To recap, there was a statistically significant improvement in both knowledge and acceptance scores before and after the intervention, a non-statistically significant increase in CGM interpretations, and a statistically significant improvement in CGM users 3 months after the intervention. The only objective that was not achieved was seeing a statistically significant increase in the rate of CGM interpretations. Although there was an increase in the rate, it was not statistically significant, and there are several possible confounding variables that may have contributed to this. First is the patient population. The data was analyzed by comparing the total number of diabetes visits that occurred 3 months before and after the intervention. However, it did not take into consideration the type of diabetes the individuals may have had, nor their current diabetes therapy. There could have been a different amount of patients who are more likely to use CGMs seen during the 2 time periods. Another factor relates to the availability of sensors. On August 27, 2024, the Food and Drug Administration issued a Class 1 recall on the Libre 3 sensors, leading to a nationwide shortage. Many patients experienced significant delays in obtaining their sensors. Patients seen in the clinic after the intervention may have been unable to get their sensors, and that could have led to a lower rate of CGM interpretations than would have occurred if there was not this lack of sensor supply. It is also possible that the lack of a statistically significant increase may be attributable to insufficient statistical power due to a limited sample size. Lastly, there is the possibility that the null hypothesis is valid and that an increase in the knowledge and acceptance of CGMs has no impact on the rate of CGM interpretation. There are several limitations to the project. First of all, the project was conducted at an endocrinology clinic, so the results may not be generalizable to primary care. In addition, there was a relatively small sample size. Next, the participants all had prior experience with CGMs, and the results may not be found in a population with minimal CGM experience. Retesting also needs to be considered a limitation because the post-test was given immediately after the educational intervention. It is possible that the increase in knowledge may not be seen had the post-test been given at a longer period of time after the intervention. Another consideration relates to the total number of diabetes visits used for the determination of the rate of CGM interpretations. As discussed previously, people with type 1 diabetes or on insulin may be more likely to use CGMs, and the results of the change in rate of CGM interpretations may be different based on analyzing more specific details about patient characteristics. In determining the prevalence of CGM use, the number of CGM users was divided by the total number of patients seen for diabetes at the clinic. A patient is considered active at a clinic if they have had an in-person visit within 3 years. The number of unique diabetes encounters that occurred at the clinic over the previous 3 years was used to determine the number of clinic patients with diabetes. Those included in that number may have established care with another provider, may have passed away, or be under different circumstances, so the prevalence of CGM use may not be accurate. These are some recommendations based on the project's findings. The practice should definitely continue its CGM program so that all patients may have the opportunity to receive the benefits that CGMs have to offer. There should also be ongoing education to ensure that the increase in knowledge and acceptance is maintained. CGM technology is advancing rapidly. In fact, during the 2 years that the project was worked on, there were upgrades to sensor technology, and new studies on CGMs are coming out frequently. Continual quality improvement programs should be developed and implemented to keep up with technological advances and best practice recommendations based on the most recent CGM studies. Additional analysis should also be conducted on the project data. First is the complete testing on knowledge and acceptance of CGMs over a longer period of time to determine if scores are maintained or if the increase was just due to retesting. The data can also be analyzed over a longer period of time or based on the type of diabetes a patient may have to determine if the project findings will persist or apply to specific patient populations. There are also other ways that CGMs can be used in practice, and additional projects should be developed to see how CGMs can be used in different ways. As CGMs are being recommended early in diabetes treatment, they may be used more often in primary care. A project should be developed to assist primary care providers in developing their own CGM programs. The project showed that an educational intervention can significantly increase the knowledge and acceptance of CGMs in an endocrine clinic. In addition, it showed that updating practice protocols and simplifying workflows can help to improve the utilization of technology in clinical practice. The patient handout was created synthesizing patient education materials created by various manufacturers into a single page with personalized clinic codes. Practices can go beyond simply using educational materials provided by industry and create materials specific to their clinic to simplify processes that patients need to follow. It also showed that an intervention on CGMs may increase the number of CGM interpretations performed. This in turn may help patients use technology to achieve their glycemic goals. These are some implications of the project. Number one is that education can increase the knowledge and acceptance of technology, and it needs to be continually updated. Second, as technology advances, nursing protocols and workflows need to be continually updated. Lastly, the project showed a quality improvement program focused on technology can increase its use. There are an immense number of patient care technologies that can be used in healthcare. Nurses have the opportunity to be on the front lines for the use of technology, and so it is essential for nurses to focus on finding innovative ways to utilize technology to fully realize the benefits it has to offer to our patients. In conclusion, the project achieved two of its three objectives: an increase in knowledge and acceptance scores, as well as an increase in the prevalence of CGM use. There was not an increase in CGM interpretations, but this could be due to the sensor recall and shortage during the study period, or other confounding factors. Additional studies can be done to determine if the intervention led to an increase in interpretations over a longer period of time. As diabetes technology is rapidly advancing, it is essential for staff to have continual education, and ongoing quality improvement projects need to be developed for the implementation of interventions related to diabetes technology. This concludes the presentation. Thank you for your participation.